him. I'm Dr. Samia ElKady, Professor of Cardiology in National Heart Institute and the previous head of Echo Department in National Heart Institute and previous head of ER in National Heart Institute. I'm Dr. Samia ElKady, Professor of Cardiology in National Heart Institute and the previous head of Echo Department in National Heart Institute and previous head of the ER in National Heart Institute. I have some questions to be answered. The first question is RV echo study truly missed? And is RV echo study actually challenging? And how RV performance is assessed? I have some questions to ask. The first question is right ventricle echo study truly missed? Second question is right ventricular echo study is actually challenging? The third question is how right ventricular performance is assessed? For the first question, is RV echo study truly missed? No, should not be missed. Why? Right ventricular performance defines prognostic and therapeutic strategies in patients with chronic lung disease and cardiovascular disease like congenital or acquired disease, pre- and post-operative. Is RV echo study actually challenging? Yes. Why? Because of retrosternal position, which limits echo imaging windows, wrapping around the LV, complex 3D geometry, and limited delineation of endocardial surface of the right ventricle caused by heavy capiculated myocardium. Regarding the anatomy of the right ventricle, it's formed of inlet part, bodified ventricle, and outlet. The inlet, the tricuspid valve, which is attached to papillary muscles by chordae tendini, and the body is heavily capiculated, and the outlet part is formed of infundibular, then pulmonary valve, then pulmonary artery and its branches. The second image shows how the right ventricle wrapping around the left ventricle, and second image shows common fibers between RV and LV. What about right ventricular hemodynamics? Right ventricular performance is affected by intrinsic right ventricular contractile status, preload, which is presented by venous return, afterload, which is presented by pulmonary vascular resistance, and the left ventricular and right ventricular interdependence. Why? Because one pericardium is wrapping around both RV and LV. The septum is working between both RV and LV, so elevation of pressure in RV affect LV and elevation of pressure in LV affecting right ventricle, and because of common fibers between the two ventricles. This is the mechanics of right ventricular contraction of every part of the right ventricle. At the level of tricuspid, during contraction, the tricuspid ring is moving towards the apex, and the free right ventricular wall is moving inwards. and the apex is moving inwards. The guidelines for echo assessment of right heart in adults. It was published by American Society of Echo and endorsed by European Society of Echo and registered branch of European Society of Cardiology and Canadian Society of Echo. And now, what's the role of echo in RV assessment? First, RV morphology for the shape and size, for the wall thickness, for dimensions, and RV hemodynamics for right ventricular pressure, right atrial pressure, and pulmonary vascular resistance, and for right ventricular function, systolic and diastolic function. Let's clarify the different parts of right ventricular wall. As the anterior wall of the right ventricle is apparent in parasternal long axis, in apical to chamber, in short axis at the level of papillary muscles, while inferior wall is apparent in apical to chambers, in short axis at the level of papillary muscles, and in short axis at the level of great vessels, and in subcostal view. The lateral wall is apparent in apical fourth chamber. Let's decide the different parts of the right ventricular wall. The inferior wall is apparent in apical two chambers, in short axis at the level of papillary muscles. This is the plaque part. And in the short axis in the level of great vessels and in subcostal view. While anterior wall is apparent in parasternal long axis and in apical two chambers, in short axis at the level of papillary muscles. The anterior wall of the right ventricular outflow is apparent in the short axis at the level of great vessels. Regarding the right ventricular size, is approximately 2/3 of the size of LV, and right ventricle is considered dilated when it's similar or larger than LV size. It shares the apex. Also, to know about the right ventricular size, there is what's known as eccentricity index, and this is the ratio of two orthogonal minor axes in short axis view at the level papillary muscles. It reflects the degree of septal flattening resulting in abnormal LV shape. Normally it's one imposed systole and diastole. And also, to clear the size of the right ventricle, there is what's known as eccentricity index. It's the ratio of two minor axes of the LV at the level of papillary muscle, which reflects the degree of septal flattening resulting in abnormal LV shape. Normally, it's one imposed systole and diastole. For RV wall thickness, it's measured either by 2D in subcostal view and by M mode in the level of two ventricles. Normally, it's apart 5 mm or less. The RV dimension is measured by 2G in apical fourth chamber by 3 axes. The first axe at the level of tricuspid valve, the second one is mid-ventricle, and the third one is a long axis from the plan of tricuspid valve to the apex. The first one is 42, while the second one 35, and the long axis is 86. Actually, it marks the RV dilatation, but it's highly dependable on endocardial delineation. For the measure of right ventricular outflow, there is right ventricular outflow 1 from the anterior wall of right ventricular outflow, the anterior wall of aortic root, and this is equal 33 millimeter or less. And the right ventricular outflow 2, this is at the level of pulmonary valve, and it's 27 millimeter. To get the right atrial pressure, it's decided or estimated from subcostal view IVC dimension. Normally the IVC is less than 2.1 and it should be collapsed more than 50% with deep inspiration. So if it's less than 2.1 and collapse more than 50, it's measuring the right atrial pressure from 0 to 5, average 3. While if it's less than 2.1 and less than 50% collapse, it's from 5 to 10 millimeter HG, average 8. And if it's more than 2.1 and collapse more than 50%, it's also from 5 to 10. While if it's more than 2.1 and collapse less than 50% or no collapse at all, the pressure in right atrium will be 15 millimeter HG. To get the right ventricular systolic pressure, we get the tricuspid regurg flow in apical four chamber or in short axis at the level of great vessels, and after deciding the velocity of tricuspid regurg 4V square equal to the pressure, it's added to right atrial pressure which previously decided, and the normal right ventricular systolic pressure is less than 35. To get the right ventricular diastolic pressure, only we can get it in the presence of pulmonary regurg. Tracing the pulmonary regurg through the right ventricular outflow by 2G and short axis great vessel level, we can get the end of velocity of pulmonary regurg flow 4V square plus the right atrial pressure. We can get the diastolic pressure, which is normally is 15 or less. To get mean pulmonary artery pressure, it's either using the pulmonary regurg flow, measuring the early velocity of pulmonary regurg, and 4V square plus right atrial pressure will get the mean pulmonary artery pressure. Or by getting third pulmonary artery systolic pressure plus 2/3 pulmonary artery diastolic pressure, or VTI of TR jet, and the mean pulmonary artery pressure normally is 25 or less. To decide the pulmonary vascular resistance, we get it by peak tricuspid velocity in meter per second divided by right ventricular outflow VTI in centimeter square, and normally it's 1.5 Wood units, and pulmonary hypertension develops with pulmonary vascular resistance more than 3 Wood units. Regarding right ventricular systolic function, we can get global function by fact by myocardial performance index, by ejection fraction, and regional function by TAPSE, right ventricular outflow systolic excursion, right ventricular S prime velocity, right ventricular stream. To get track, we have to decide the right ventricular area in systole and diastole in apical fourth chamber by 2D, and the fact is estimated by end diastolic area minus end systolic area divided by end diastolic area multiplied by 100. Normally, RV fact is more than 35%, and this correlates with ejection fraction by MRI. The second method to assess right ventricular global function is right ventricular myocardial performance index, which is known as TI index. We can get it by pulsed Doppler through the tricuspid valve, getting the diastolic flow and the systolic flow. Isometric relaxation time is the time between systolic flow and the start of diastolic flow. Isometric contraction time is the time between the end of diastolic flow and the start of systolic flow. And the myocardial performance index equal isometric contraction time plus isometric relaxation time divided by ejection time, and it's equal to 0.4 up to 0.55. And also we can assess through TDI, getting the myocardial performance index, again the isometric relaxation time plus the isometric contraction time divided by ejection time. The third method to assess right ventricular global function is by assessing ejection fraction through 3D echo. 2D echo is not recommended because of heterogeneity of methods and numerous geometric assumptions, as 3D echo is more accurate using disk submission and apical rotational methods volumetric measures. Normal right ventricular ejection fraction is more than 44. For right ventricular regional function, we are using TAPSE. TAPSE means tricuspid annulus systolic excursion. We can measure an apical fourth chamber with M-mode cursor at the end, lateral end of tricuspid annulus, and getting the systolic excursion. Normally it's 1.6 cm, and it's very easy method. When TAPSE equal 2 cm, ejection fraction is 50. TAPSE 1.5 cm, ejection fraction is 40. TAPSE with 1 cm, ejection fraction 30. TAPSE with 0.5 cm, ejection fraction is 20. And actually TAPSE is correlated with survival, as the higher the TAPSE, the higher survival. The second method is right ventricular outflow systolic excursion, and we can get it in short axis at the level of great vessels. We get the M mode to get the systolic excursion of the anterior wall of the right ventricular outflow, and normally it's 6 mm. It's related to survival, as the higher the systolic excursion is, the higher the survival. The third method is right ventricular S prime velocity, and we can get it by TDI in apical flow chamber at the lateral end of tricuspid annulus. Normally, it's 10 cm per second. It's simple method and good discrimination between normal and abnormal RV function, but it's angle dependent and measures only basal free wall segment. The first method to get regional function is right ventricular strain, and it's by pulsed Doppler strain for the free right ventricular wall in basal portion, mid portion, and apical portion. It's less load dependent, but it's angle dependent and lack of normal data. The fifth method for right ventricular strain is by 2G strain. This is by speckle tracking around the right ventricular wall and septum. This is angle independent, but there is lack of normal data and doesn't represent the true global function of complex RV morphology. Also, right ventricular strain, we can get it by 3G strain. This is more reliable based on volumetric assumption, but it's complex technique with lack of normal data. For right ventricular diastolic function, we have many methods. Pulsed Doppler across the tricuspid valve flow, getting E and A and E to A ratio, deceleration time and isometric relaxation time. Tissue Doppler velocity across the lateral end of the tricuspid annulus, getting E prime, A prime, and E to A prime ratio, and also can get E to E prime ratio, right atrial area of volume, and right ventricular diastolic strain. This is the diastolic flow across the tricuspid valve, the same as mitral valve, but with lower velocity and apparent respiratory changes. This is the diastolic flow across the tricuspid valve, E and A wave, and the normal E to A ratio is 1. Deceleration time is 120 milliseconds. Deceleration times is the time elapsed between the peak velocity of E wave till the velocity is 0. This is again the diastolic flow across the tricuspid valve, and TDI across the lateral end of the tricuspid annulus, getting E and E prime level. This E to E prime ratio should be less than 6. Also, to get right ventricular diastolic function, we should get the right atrial dimension and area. Normal right atrial major dimension is less than 53 mm. Normal right atrial minor dimension is less than 44 mm. And the normal right atrial area is less than 18 cm square. For grading of RV diastolic dysfunction, E to A ratio less than 1, this is impaired relaxation. E to A ratio from 1 to 2.1, and E to E prime more than 6 is pseudo-normal filling. deceleration time less than 120 millisecond, and E to A ratio more than 2.1. This is restrictive filling pattern. Take-home message: right ventricular function has important prognostic and therapeutic implications in patients with primary lung disease and cardiovascular disease. Assessment of RV performance is mandatory during routine clinical echo analysis. There are several simple reproducible methods of RV assessment such as FIC, PEPSI, S', and TI index. However, being load dependent, identifying an accurate, reliable echo parameter for RV assessment is challenging. Deformation RV studies are less load dependent, yet they still have limitations because of lack of normal data. Moreover, true global assessment is lacking, being derived from single view. 3D echo-derived parameters may add value to RV examination, but validation studies are still needed. E to A ratio, E to E prime ratio, deceleration time, right atrial area are the most validated measures of RV diastolic function, so combined projection and parameters are needed to give more informative analysis of RV performance. Thank you.